This was an analysis where we were looking at the trials that were already done and sort of building on the PK models that had already been constructed. So we already had data for TIVO monotherapy from TIVO3 and others. And as we designed TiNivo2, one of the key questions was, what is the effect of Navolaab on Tivozanib, specifically on the incidence of hypertension? So this analysis really wasn't to say what is the most effective concentration of Tivozanib, but what this analysis did show was that the Tivozanib concentrations were dose dependent. So with higher doses, we got higher dose concentrations, and those concentrations were independent of concomitant Navolaab administration. So what we were able to show in this EM model was that 1.34 milligrams provided the greatest anti-tumor activity. And so that would tell you that if you're giving a patient 1.34 versus 0.89 with another drug, if there's no contribution of that second drug, that the patients who receive the higher dose may have a numerically improved PFS, which is what we saw in the analysis. And so I think this really does highlight the point that as we are looking to develop new regimens for our patients and improve outcomes, optimizing the TKI dose actually really is important. And right now, that is going to be a way to get the best benefit for our patients. And Tivozanib is obviously very appealing in that patients can often tolerate the higher dose, and less than 20% require dose reductions from 1.34 milligrams, day 1 through 21, every 28 days. As we look at Tivozanib, or really any TKI, again, dose matters, and so starting with the highest dose is important and reducing as needed for toxicities. To that extent, hypertension is a very common toxicity with any of the TKIs, and early intervention is critical. So recognizing the patient has hypertension, seeing them on a regular basis early on, adjusting meds early on to optimize blood pressure before it gets out of control is a way to maintain the optimal dose for the patient. And I think this data is quite compelling as I look at a trial that has been developed with Alliance, AO32201 or STRIKE, which is looking at the role of pembrolizumab with or without Tivozanib in the adjuvant treatment of high-risk renal cell carcinoma. And we, after seeing the TiNivo2 data, like to use the higher dose Tivozanib in the trial. And I think this analysis would support that the higher dose Tivozanib would pair well with immunotherapy without any increased risk of hypertension. This data complements what we'd already seen with CONTACT-3, which looked at the role of cabozantinib with atezolizumab versus cabozantinib alone in patients that progress immunotherapy. This is a little bit different data set in that, in this trial, we use a PD-1 inhibitor, not a PD-L1 inhibitor. And there was a subset of patients, about a third or so, that had an intervening therapy between progression and immunotherapy and enrolling in a trial. Despite these differences, both trials showed exactly the same thing. There was no improvement in outcomes with the addition of immunotherapy to a TKI in patients who progress on immunotherapy prior to enrolling. So I think that's key. I think, again, both trials sort of support the same thing. In CONTACT-3, they optimized dose. So both arms received high-dose cabo at 60 milligrams. And while there's no difference in outcomes, there was an increase in toxicity. In TiNivo2, where there was concern about the increase in hypertension with a combination, a lower dose of TKI was chosen for the combination, and we saw numerically worse outcomes in that arm. Again, emphasizing that optimizing TKI dose as a monotherapy with available drugs right now is our best strategy. This is compelling data that truly augments the clinical results we've seen already. Tivozanib is a well-tolerated TKI with a favorable safety profile. And as we think about advancing in care in the adjuvant setting, while IO and TKI is a standard care in metastasis, we actually haven't had trials in the adjuvant setting. So I would encourage everyone to consider supporting the ongoing STRIKE trial, which is open through Alliance, which is trying to answer this question of, does a short course of Tivozanib at full dose, 6 months with a year pembrolizumab improve outcomes versus a year pembrolizumab alone in patients with high-risk resected RCC, again, with that dosing really supported by this data.